Good evening, ladies and gentlemen. This is the second part of the lecture which I delivered in the morning. Since that lecture ended abruptly, I have to record a second lecture to complete the topic. And the topic which I was discussing in the morning was herpes virus infection. So I'll start the lecture exactly from where the last lecture ended. The trigeminal nerve zoster. In ophthalmic nerve zoster, the eye is affected in 2/3 of the cases, especially when the vesicles occur on the side of the nose that indicates the involvement of nasociliary nerve. And in this case, the eye lesions within the eye are definitely seen. This is the Hutchison sign. The ocular complications include uveitis, keratitis, conjunctivitis, conjunctival edema, paresis of the ocular muscle, proptosis, scleritis, the retinal vascular occlusion, ulceration, scarring, and even necrosis of the lid. This picture shows the ophthalmic zoster involving the eyelid with gross edema. Involvement of ciliary ganglion may give rise to Argyll-Robertson pupil. The zoster of maxillary division of trigeminal nerve produce vesicles on uvula and tonsillar area, while involvement of mandibular nerve produce vesicle on the tip of the tongue and floor of the mouth. The orofacial zoster toothache may be a presenting symptoms. Then herpes zoster oticus. Varicella zoster virus, if involves the sensory component of facial nerve, then it will cause pressure on the motor fibers, which result in the classical triad of Ramsay-Hunt syndrome. And the Ramsay-Hunt syndrome comprises of facial palsy, ear pain, and associated vesicles on the pinna. Compression of the vestibulocochlear nerve may give rise to sensorineural hearing loss, dizziness, and vertigo. And involvement of nervous intermediates will result in loss of taste in anterior 2/3 of the tongue and alter lacrimation. Herpes zoster oticus accounts for 10% cases of facial palsy. Then the post-herpetic neuralgia. Persistence or recurrence of pain more than a month after the onset of zoster, but better consider it after 3 months. So if the pain is persistent after a month of healing of the vesicles, then you can consider it as post-herpetic neuralgia. This is unusual in childhood, and the incidence increases as the age advances, and incidence is quite high in patients who are above 50 years of age. And it is most common in ophthalmic zoster and in other trigeminal nerve zosters. And pain has 2 main forms. It may be a continuous burning pain with hyperesthesia or a spasmodic shooting pain. The neuralgia varies from inconvenience to severely disabling. Then the disseminated herpes zoster. The disseminated herpes zoster is usually defined as a generalized eruption of more than 10 to 12 extradermatomal vesicles that occurring 7 to 14 days after the onset of classical dermatomal herpes zoster. So these vesicles, at least 10 to 12, will be present on different parts of the body away from the specific dermatome where the herpes zoster occurred. And these lesions are clinically indistinguishable from the chickenpox. Dissemination occurs in approximately 2% of herpes zoster in immunocompetent individual, but the percentage increases to 35% if the patient is immunocompromised or hospitalized. Complications. The complications of herpes zoster include scar sarcoid, secondary bacterial infections, encephalitis or meningoencephalitis, acute retinal necrosis, and Guillain-Barré syndrome, and transverse myelitis. Diagnosis. The bedside diagnosis is Zank smear, in which we demonstrate multinucleated giant cells. It has, however, lower specificity and sensitivity as compared to PCR. Then the most commonly done procedure nowadays is varicella zoster virus immunoglobulin. If we find IgM in this serological test, then it shows an active infection of chickenpox or shingles, and IgG just shows antibody produced because of old infection. Direct fluorescent antibody testing of vesicular fluid or corneal fluid can be done. PCR testing of vesicular fluid or blood in case of disseminated infection. Virus is readily identified by electron microscopy of the vesicular fluid and can be grown in tissue culture. Then varicella zoster virus vaccine. Pre-exposure prophylaxis. A live attenuated vaccine developed from the OCA strain of varicella zoster virus is effective in preventing varicella in healthy children. This vaccine is given in 2 doses 3 months apart and resulting in 90% seroconversion and protection. The vaccine is also used in children with HIV and CD4 count of less than 200 cells per microliter. Post-exposure prophylaxis. This is done by intravenous immunoglobulins administered within 10 days of contact to reduce the severity of varicella zoster, but varicella does not always prevent it. It should be given to neonates whose mother developed varicella within 7 days of delivery and 7 days after delivery. Some advocate additional intravenous acyclovir for the mothers before the delivery and neonate after delivery. The immunoglobulin prophylaxis is also given to exposed non-immune pregnant women, not only to reduce the severity of chickenpox, but also reduce the risk of fetal transmission. In later life, immunity against varicella zoster virus wanes, but may be boosted intermittently following contact with chickenpox patients. So once the immunity of chickenpox develop either due to vaccine or by an infection, it usually persists because the contact with random patients of chickenpox continues throughout the life, and this contact acts as booster. Antiviral prophylaxis. This is a frequently asked question. An immunocompetent person, acyclovir given from about 9 days after exposure to 1 week for 1 week appeared to be effective in aborting or reducing the severity of chickenpox and allows the immunity to develop. So this is important. That is, if you want that other children in the household should not develop chickenpox, then the acyclovir prophylaxis should be started 9 days after the 9 days after the rash has developed in that individual. So this interval will help in developing the immunity and also restricting the severity of chickenpox in other contexts. Prophylaxis with acyclovir is effective in preventing zoster in early months following a bone marrow transplantation. So this is must treatment in case of bone marrow transplantation. Treatment. Use of acyclovir in childhood chickenpox reduce the severity and duration of eruption. Rest and analgesia are sufficient for mild attack of zoster in young. Soothing antiseptic application may be helpful, and secondary bacterial infection will require antibiotic, oral or topical. An antiviral is indicated for varicella in adults and for severe varicella and zoster infection at any age in immunocompromised. So in a summary of above is that every young boy should be treated with acyclovir, and the concept that let the virus erupt is not correct, because the early treatment will prevent the consequences, complications, and definitely the aesthetic or cosmetic implication of chickenpox. But in adult, the treatment with acyclovir is must, because their chances of post-herpetic neuralgia is very high in adult, and it should be given to every patient who is immunocompromised, because it can lead to disseminated and severe infections. And treatment should be started as early as possible within 1 to 2 days. However, this virus is less sensitive to acyclovir as compared to herpes simplex virus. The dose of intravenous acyclovir is 10 milligram per kg or 500 milligram per meter square 8-hourly intravenous. The dose in herpes simplex is 5 milligram per kg. Zoster is often treated with acyclovir 800 milligram 5 times a day for 7 to 10 days. The similar dose in herpes simplex is 200 milligram 5 times a day. Valcyclovir is given as 1 gram and famciclovir as 500 milligram 3 times a day. The dose is half in herpes simplex. Such treatment prevents progression of eruption, reduces the systemic complication of varicella and in zoster, and lessens the pain and post-herpetic neuralgia. If first division of trigeminal nerve is involved, there are risk and damage to eyes, risk of damage to eyes. So antiviral therapy and ophthalmological consultation is must. In Ramsay-Hunt syndrome, steroid therapy should be started under cover of antiviral or acyclovir therapy. Treatment of post-herpetic neuralgia. All patients who are suffering from post-herpetic neuralgia must receive methicobol. And for relief of pain, paracetamol or NSAIDs are given for variable period of time. Tricyclic antidepressants like amitriptyline, nortriptyline is given for hyperesthesias and burning pain. The dose is 25 milligram at night for 3 to 6 months. For stabbing and shooting pain, clonazepam, carbamazepine, and sodium valproate is given. New drugs like gabapentin and pregabalin have now replaced these tricyclic antidepressant and other anticonvulsants for reduction of pain. Then topical capsaicin 0.025% capsidol cream, which is a substance P depleter, is quite effective. And topical anesthetic applied as cream or patch can also give relief. Then the human herpes virus 4 or cytomegalovirus. There are several ways of transmission of cytomegalovirus, which varies with age. The intrauterine transmission occurs in 0.1 to 1% of births. Perinatal or neonatal infection arise as a result of exposure of infectious cervical secretions in birth canal or from the infected breast milk. So in addition to the intrauterine infection, cytomegalovirus is also transmitted through cervical secretion and by breast milk. The preschool children may acquire cytomegalovirus from oral secretions or urine from other infected infants or children. At an older age, sexual transmission is also important. Blood transfusion is also a source of cytomegalovirus. The virus is being associated mainly with neutrophils. Cytomegalovirus may be transmitted in a transplanted organ from a cytomegalovirus seropositive donor. So a donor who has who suffered from cytomegalovirus can transfer this virus to the recipient. Clinical features: congenital cytomegalovirus infection. So primary infection in the first or second trimester of pregnancy. The infant is suffering from hepatosplenomegaly, jaundice, and purpura. Most of them die within 2 months, and survivals have severe neurological damage, especially deafness. There may be erythropoietic tissue in the dermis derived from undifferentiated dermal mesenchyme that present as purple or red papule or nodules that last for 4 to 6 weeks. These lesions are called as blueberry muffin lesions. These are the blueberry muffin lesions. Then cytomegalovirus mononucleosis. The symptoms do appear. They resemble infectious mononucleosis with Epstein-Barr virus and is characterized by fever, lymphocytosis, mildly deranged liver functions, although lymphadenopathy and splenomegaly are usually not striking. In up to a third of cases, there is follicular, maculopapular, or rubelliform eruption. Ampicillin commonly triggers the eruption as it does in infectious mononucleosis. Other association of cytomegalovirus, it can be a precipitating factor in scleroderma, in systemic sclerosis. in vitiligo, in alopecia areata, but all these associations are not proven. The genetic Rossi syndrome may occur together with cytomegalovirus infection. Diagnosis. It is histologically diagnosed by finding typical intranuclear intrusions. Then it can be detected within 24 to 48 hours in viral cultures. Direct detection of cytomegalovirus antigenemia and viral DNA by PCR. Primary infection can be diagnosed serologically by IgM or IgG antibodies. This is a very common laboratory test nowadays. Congenital cytomegalovirus can also be diagnosed confidently by viral isolation or presence of cytomegalovirus IgM antibodies within 3 weeks of childbirth. Treatment. The drug of choice for cytomegalovirus disease is intravenous ganciclovir. Although ganciclovir may be used for non-severe cytomegalovirus treatment in selected cases. The ganciclovir is a nucleoside analog that inhibits DNA synthesis in the same manner as acyclovir. The major difference is that cytomegalovirus does not contain thymidine kinase. The ganciclovir 900 milligram once orally is equivalent to once daily intravenous ganciclovir. So the advantage of ganciclovir is that it is given in oral form, while ganciclovir is given only in intravenous form. Human herpes virus 5 or Epstein-Barr virus. The Epstein-Barr virus usually infects the B lymphocytes and occasionally T lymphocytes or squamous epithelial cells. The primary infection is followed by lifelong persistence of the virus in latent stage in the resting B cells. And under certain circumstances, these cells are activated when a range of viral and cellular proteins are expressed. In oropharynx, liberation of virus into saliva explains the spread of infection between individuals. And Epstein-Barr virus is associated with nasopharyngeal carcinoma and with various B lymphoproliferative lesions. Epidemiology. In early childhood, the virus is probably spread by contact with saliva on fingers or fomites. In more developed communities, primary infection occur most commonly in early adult life, when kissing is the usual route of infection, though occasionally droplet spread may occur. Clinically obvious infectious mononucleosis is more frequent. Infectious mononucleosis or glandular fever. The infectious mononucleosis is characterized by fever, sore throat with exudative pharyngotonsillitis, petechiae at the junction of hard and soft palate, a macular, maculopapular, morbilliform, or scarlatiniform eruption at 4th to 6th day on trunk and limbs, then lymphadenopathy, splenomegaly in half of the patients, lymphocytosis with at least 10% atypical cells, and jaundice in 4%, which indicates the hepatocellular damage. This is now a serious consequence. If ampicillin is taken during the course of illness, an extensive maculopapular or morbilliform eruption develops in over 90% of the cases. Similar effect is occasionally seen with penicillins, tetracyclines, and azithromycin. The cold agglutinins are common in infectious mononucleosis, which might explain the occasional cases of transient cold urticaria. Splenic rupture and encephalitis are life-threatening complications. Diagnosis: examination of blood film for abnormal lymphocytes, test for heterophil antibodies, which is the Paul-Bunel test, that agglutinate sheep or horse red cells become positive in 90% of patients within 1 to 2 weeks. During the infection, the antibodies to Epstein-Barr viral capsid antigen is produced, IgM for a few months and IgG for life. Viral DNA is detected by PCR. So the treatment is mainly of infectious mononucleosis is mainly conservative, and symptomatic. Another infection caused by Epstein-Barr virus is oral hairy leukoplakia. This oral hairy leukoplakia develops insidiously as white plaques on the side of the tongue. This disorder is due to reactivation of Epstein-Barr virus infection and occurs in association with immunodeficiency due to HIV, hematological malignancies, or immunosuppressive treatments. Pathology. The Epstein-Barr virus replicates in maturing epithelial cells, but is not present in basal keratinocytes. So clinically, it will give appearance of white rippled plaque developing unilateral or bilateral on side of the tongue that may appear to have a hair-like projections. In more advanced disease, the plaques may extend over the tongue and into the oropharynx. The DD to be considered here are lichen planus, candidiasis, and squamous cell carcinoma. Then the lymphomas and lymphoproliferative disorders that are associated with EBV. Burkitt lymphoma, which occurs in equatorial Africa and present classically as huge cervical lymphadenopathy. Nasopharyngeal carcinoma reported in Asia and often preceded by prolonged elevation of antibodies to EBV. Then many B-cell tumors, especially the large cell lymphoma, occur in immunocompromised. The natural killer or T-cell lymphoma is rare. Then there is a syndrome called as hemophagocytic lymphohistiocytosis. It is a histocytosis and is first described in genetic immunodeficiency syndromes, but also occur in immunosuppression associated with Hodgkin lymphoma or by transplantation. There is high viral EBV load in blood as well as elevated acute phase proteins. The disease presents as fever, pancytopenia with coagulation defects, lymphadenopathy, hepatosplenomegaly, hemorrhage into the lungs, bowel, meningitis, and encephalitis. Maculopapular rash with epidermal necrosis or nodules with granulomatous inflammation is also seen. Treatment is always supportive and rapid commencement of immunosuppressives as well as antiviral treatment. Other cutaneous manifestations of Epstein-Barr virus, the genetic Crosty syndrome, Kikuchi histocytic necrotizing lymphadenitis, Lipschutz ulcers, which are painful genital ulcers that occurring in adolescents without a venereal infection associated with inguinal lymphadenopathy. Then several reactive dermatoses like erythema multiforme, erythema nodosum, erythema annulare centrifugum, acute pityriasis lichenoides, and chronic bullous disease of childhood may also develop as a result of Epstein-Barr virus infection. Then human herpes virus 6. This is originally isolated in 1986, and the virus is very close in its structure to Cytomegalovirus. There are two distinct types, A and B. The virus causes roseola infantum, also known as exanthum subitum. The most common exanthemic fever in children under the age of 2 years, with peak incidence between 6 and 9 months, and reported to account for 24% of acute febrile illness presenting as a pediatric emergency department. After an initial infection, the virus persists and can be detected in saliva from a high percentage of healthy subjects. The roseola infantum or exanthum subitum is characterized by an incubation period of 10 to 15 days and fever that ranges between 39.5 to 40 degrees, begins abruptly and persists for 3 to 5 days. There are inflamed tympanic membranes, ulcers at posterior palate and uvula, and occasionally periorbital edema and hematuria. As the temperature gradually declines, an eruption of discrete rose-pink maculopapules develop on neck and trunk and later on spread down to arm and legs and up to the face. After 1 to 2 days, the rash fades, leaving no scaling or pigmentation. So a high grade fever, and as the fever subsides, the rash emerges. This is typical. The patient's cervical and occipital lymph nodes are usually enlarged. Febrile convulsions are not uncommon. Diagnosis: lack of symptoms during febrile phase and appearance of eruption as the fever subsides should suggest the diagnosis. Confirmation is done by demonstrating seroconversion or rise in antibody titer of herpes simplex, herpes virus 6. This is done by taking a paired serum that is 2 weeks apart. The first serum immediately as the rash developed, as the fever developed, and the second one after 2 weeks. The molecular detection of viral DNA by PCR is also possible, and treatment is only symptomatic. Antiviral treatment with ganciclovir, cidofovir, or foscarnet would be appropriate in individuals with severe disease. Then comes the herpes virus 7 or roseola infantum. This virus is also very prevalent and infecting children at age similar to human herpes virus 6, that is 2 years or less. At present, it is not known if herpes simplex virus 7 specifically is related to any disease, but like herpes virus 6, it is reported in illnesses with clinical features similar to exanthum subitum or roseola infantum. So it will cause a disease similar to human herpes virus 6. Herpes virus 7 viral DNA is detected in blood and lesional skin of patients with P. rosea as well. Then the last herpes virus is human herpes virus 8, which is the Kaposi sarcoma associated herpes virus. This virus is also found in association with classical Kaposi sarcoma in immunocompetent people and in post-transplantation Kaposi sarcoma. So whatever is the cause of Kaposi sarcoma, this virus is present. Prolonged immunosuppression for other reasons, including pemphigus, is rarely associated with this virus infection and Kaposi sarcoma. The primary infection with HH virus 8 may be subclinical or may occur with fever and maculopapular eruption. The Kaposi sarcoma DNA, Kaposi sarcoma virus DNA is detected in 98% of Kaposi sarcoma lesions and is present in monocytes, in endothelial cells, and in spindle cells. Many of the viral proteins trigger cell proliferation, angiogenesis, and apoptosis and downregulate the local immunity. So this viral protein is itself a trigger to malignancy. Treatment. The primary infection is frequently subclinical. There is some evidence that ganciclovir may reduce the viral replication in primary or reactivation episode. Regression of lesions frequently occur in AIDS with antiretroviral treatment and post-transplant with reduction of the immunosuppression, Local treatment include the cryotherapy, radiotherapy, intralesional chemotherapy, intralesional interferon, and topical 5% imiquimod cream. The last topic of this lecture is Kaposi varicelliform eruption, also known as Eczema herpeticum. It is referred to a widespread cutaneous infection with a virus which normally cause mild vesicular eruption, and this disease occur in patients with pre-existing skin conditions. Great majority of cases, the virus which is infecting is herpes simplex virus type 1. This is now called as Eczema herpeticum. Other common viruses which cause this eruption is Coxsackie N16 or Vaccinia virus, and the eruption due to Vaccinia virus is called as Eczema vaccinatum. The susceptible dermatosis. Atopic eczema is by far the most commonest, and other eczemas include allergic and irritant contact eczemas. Then several blistering dermatoses include Darier's disease, pemphigus foliaceus, Hailey-Hailey disease, Grover disease, and staphylococcal scalded skin syndrome. Ichthyosiform dermatosis like Ichthyosis vulgaris and congenital ichthyosiform erythroderma. The susceptible dermatosis also include psoriasis and PRP, and malignancies like cutaneous T-cell lymphoma and Sézary syndrome. Pathogenesis. Kaposi varicelliform eruption may develop after cosmetic procedure to face and following burn, dermabrasion, or laser surgery. Most commonly seen in second and third decades, they can be widely disseminated through hematogenous spread. Patients who develop eczema herpeticum are usually immunocompetent and have developed antibodies against the virus. The clinical feature: incubation period is 10 days, range between 5 to 19 days. Vesicles rapidly become pustular, erupt in massive crops. Lesions are monomorphic, not polymorphic as in chickenpox, and is confined to the abnormal skin but often widely disseminated, simulating chickenpox. It can be hemorrhagic and face may become grossly edematous. So these are the monomorphic vesicular rash. Now, in the other picture, the rash is now drying up and crusting is seen. New crop of vesicles may appear for 5 to 7 days. This is rare. Fever, which may be high, develop 2 to 3 days after the onset of eruption, and constitutional symptoms may be severe. Regional lymph nodes are also enlarged. Treatment and prevention. The severe cases should receive intravenous acyclovir as early as possible. Less ill patients respond well to oral acyclovir or one of the newer anti-herpes agents. Infection in pregnancy has been treated with acyclovir without adverse effect to baby. Bacterial infection and underlying eczemas or other dermatoses should be treated in the usual way, but first treat the eczema herpeticum and then start the treatment. The continuous use of steroid may be advisable until the more cautious use of steroid is advisable until the viral lesions have healed. So it is better to treat eczema herpeticum first and then go for the treatment of the underlying dermatosis. That ends the lecture on herpes viral infections. So see you next time with another portion of my lectures. Thank you very much and have a good day and good weekend.